ongoing webinar series on strategies and technologies that advance access to hepatitis B and hepatitis C prevention, care, and treatment so that we can reach elimination goals for both of those viral infections. Today, we'll be focused on ways of expanding hepatitis B testing with HBsAg point of care models of testing and linkages to care. Next slide, please. So I want to welcome all of you to this ongoing webinar series where we really focus to supplement information that's typically delivered at major liver association events such as AASLD that was just convened last week. We really take this webinar series to really bring people who are implementing hepatitis, in this case, hepatitis B viral screening, to share their lessons learned so that we really can learn from others that are on the front line of delivering this key service that opens access to hepatitis B care and treatment for the 250 million plus people chronically infected with hepatitis B virus. I want to thank Abbott for the support of this webinar. Next slide. And as we begin the presentations, please submit your questions to the Q&A box, which is found at the bottom of your Zoom screen in the Zoom menu. The webinar is recorded and will be posted on our website at globalhep.org, along with all the presentations. And stay up to date about all of the coalition activities, including future webinar events, by signing up for our newsletter, which you can do by clicking on the QR code here at the bottom right of the screen, or just going to globalhep.org, finding newsletter, and signing up. We have done at least over 70 webinars on a variety of different topics as part of our webinar series, including those that are focused on hepatitis testing and linkage to care. And this is the 10th edition of that webinar series focusing on hepatitis testing. Next slide. So today we have 4 presentations that you'll be hearing from experts presenters that you're seeing here. Then followed by a presentation from Abbott Laboratories to present the information about the new triplex test they have for HIV, hepatitis B, and syphilis. That will be part of our panel discussion. And again, I greatly encourage you to submit your comments in the chat box and your questions in the Q&A box so that you can be part of this discussion. Thank you. Now let's begin our presentation. It's my pleasure to welcome Dr. Masiano Ochuoto, who's a senior research scientist at the Kenya Medical Research Institute. Please, Masiano. Please take yourself off mute, please.
Thank you for the introduction, and I'm going to share my slide. And I'm going to share my slide with you in Can you hear me?
I can hear you fine. We're not seeing your screen at the moment.
There we go. There I share my slide. Are you able to see my slide?
No.
Yes, we can. If you could go to presentation mode. There you go. Perfect. Yes, we can. Please proceed.
Thank you. I'm going to share the insights on scaling up screening and antenatal care in Kenya. and also the outcome of what we have. I do not have something to disclose. Let me start by this call for action. And when I was in grade 10, a friend of mine lost one of the relatives, and was the sister. And during this time, what happened is the sister was married. She was divorced because of being sickly, and then she had extended stomach. And when she died, she was buried at the parents' home. Thereafter, a few years later, we came to learn that she had hepatitis B. And 2 years later, the two sons died. What am I saying? Hepatitis B wiped out an entire generation of that family. And if these ANC programs, which I'm going to share with you, were there during such a time, that could be averted. What is this hepatitis B? It is a very small virus, which is a DNA, and it infects the liver. And it has two outcomes, self-limited and also chronic. For those who extend to chronic, 10% of the adults and up to 95% of the children, they develop cirrhosis and death. In terms of global, 254 people globally are infected chronically. And each year we do have between 800,000 and 1.2 million deaths, including that of my friend who died that time. 1.2 million of new cases each year are reported, and hepatitis B is actually the cause of premature death. Globally, if you look at the distribution, I know this will be shared again and again. Africa and Western Pacific have the biggest share of that. In terms of Kenya, we do have it at 3.5% as prevalence, and that is translated to 1.1 million. In some regions in the country, especially where we come from and other places, the prevalence is quite high, up to 7.6. We have done a number of studies, especially on pregnant women. This started some years back in 2016, where we did it in the capital city, that is in Nairobi, and the prevalence by that time, it was 3.8. But we also experienced limited access to hepatitis B test as a main barrier, awareness and stigma, and also vaccination gaps, which were many people didn't know about the vaccination, especially of those who are positive. We repeated this in 2019. This time round, we treated the mothers who were positive and introduced birth doses. And we had 1.1, which was the prevalence then. But the main thing which we really accomplished by that time is that all the children who were born of positive mothers were vaccinated, and we averted that 3 possible hepatocellular carcinoma. What that taught us is that the main barrier for quality testing was limited access to test kits and reagents. This was main. Fragmented testing points in the various places in the lab at the ANC, and getting the results took a long time. And in some facilities, they were not able to test hepatitis B, so they referred these people to other places. I'm going to talk of these 4 and how we tried as much as possible to increase testing in those areas by looking at those barriers. We did this using a multiplex and a multiplex approach in rural areas, actually rural facilities and the primary healthcare in these areas here, which were southern part of Kenya. And the tests which we used, it was a prototype which was provided by Abbott. This prototype had the 4 diseases, test for 4 diseases, that is HIV, syphilis, hepatitis, and malaria. Remember, malaria is not part of the triple elimination. And this test used only 1 finger prick. And through that 1 finger prick, the blood will be sprayed here. You have 1 here, you have a drop here, and all this. And you wait for 15 minutes for you to get the results. We integrated this process into the primary healthcare services, and therefore that was very seamless. And whatever at the healthcare was done, we integrated to that, especially the HIV program. And we started by training. In the training, we trained the nurses, not necessarily on how to use our RTK, but on how to do the test and test the disparities and how to improve the outcome. What we realized is that they were competent and they could use the RTKs very well. When we asked for their perception, 90% of them gave it 5 out of 5. and that means it was excellent. And the reasons why they did so is effectiveness, and it was accurate, it saved time, and it minimized the movements. Some of them cited early detection, especially for the HIV, because it had a P24. What we did is we did up to 577 women, especially those who are coming to the second test. And we confirmed the results of them, or what was indicated in their book, which is the ANC book. And we tested them using the panel, which was the 4 ANC panels. And we digitalized this, and I'm going to talk about the digitalization and how important it was. We gave them the results, and we assessed also their experience. What we realized is that hepatitis actually has a high opportunity. That opportunity is up to 99.3. This is because by the second visit, all 99.3 mothers already have been tested using RTK. And that tells you how important it is, especially those who are doing it within the facility and those who can be referred. But the main thing is that we have a huge opportunity, especially for hepatitis B, to introduce this at the ANC and have very high results. Of the tests that were done, most of them had 2 or 3, and very few had up to 4 tests. Of those 2 and 3 tests were actually HIV, syphilis, and malaria. Hepatitis was very low in terms of that testing. That means that if we introduce this at the ANC, we are able to get 80.5% of those who have never been tested. The distribution wasn't even because some of the facilities had very high tests at that particular point. What lessons do we learn? I'm going to take through around 5 or 6 lessons that we learned. The first one is that by using a multiplex test, we actually increase the availability of tests to those facilities because 80% of them said shortage of reagent and stockout was the main barrier of them testing. And that means that by introducing a test that can do up to 4 or up to 3 tests, will make it available, and that will break that barrier. The other barrier was about the workflow. Mother will come to the facility, she waits for her turn, she goes to the ANC, test in the lab, go to test in the lab, wait for the results before going home. But in this multiplex, you realize the mother will come and wait, go to the ANC or the lab, test all the 4, and then she goes home. That saves time. And not only that, the where and when to test. That really improved because even if it's coming to second or third visit, she will be able to be tested quickly and go home. The other thing is on management of time. That was well done because this test will take a very short time. It saves actually up to 66.3 of the mother's time. And remember, where we were doing this was a primary healthcare, and 5 of 8 of them had only 1 nurse in the whole facility. Saving time will really save and increase the number of people who are tested at that time. Referring, it actually completely reduced the referral. I want to take some time on data consolidation because this is very important. Why? Because by collecting data from the 4, we improve the disease management, both for the patient and also for the care provider. So the patient will get the data, the patient will know, or the patient will be addressed at that point. And looking at the goals of the triple elimination, this actually harmonizes so well with the triple elimination. Why? Because it improves the consolidation of data and minimizes any data missing. In the competency, we do know the competence of the kit, and that will also increase that and the accuracy of that. If this data is translated into the national system, it will help in timely decision. So integrating and making sure that we have all the 4 data was really a major improvement in terms of the testing. Let me take you slightly outside the data collection and how to manage the data. For us, we only did data for testing and linkage. Those are the things that we improved and digitalized. However, we do have opportunity of using this multiplex also to go to building capacity and also management, care and management, and especially the birth doses, because this will help you in tracking those who are positive and those who have been given the birth doses. So there is an opportunity, especially of digitalizing the data that is collected from this. Let me look at the the affordability of this ANC. We asked them who meets the costs, especially the travel costs and also for the facility. Majority of them being in rural areas, this was expected, that male are the one who took care of that. However, some of them were able to do it by themselves. I want to draw you to the attention of those who said the parents. These were actually the adolescents and those who had early pregnancies. We would like that the programs that are reset, they will also take care of this, because this group here is actually fragile and not many of them will make all the visits to the facility. And looking at it, most of them actually didn't have the insurance, and therefore the insurance component in terms of meeting the cost in some places may not be feasible. In the cost, we looked at, was there any cost benefit by using a 4 test and vis-a-vis using one? Yes, there was. To the facility, especially the health facility, it will actually help save 47.4 of the facility. This goes to the consumables and overheads, and especially knowing that this is only one finger prick for it to test all the 4. And for the mother, it actually improved, not necessarily on the distance, but it will save in terms of the time that is spent. It will save by 9.5. In fact, when we gave these results, one of the mothers was excited, and this is what she said: "This is a game changer, for I will not waste time to follow up my results again." Let me conclude by saying this, that using a multiplex is really a good approach, and it will scale up the testing, and more so for the hepatitis B, which is lagging behind, and it will improve the access to the facility. And integration is a way to go. For us, we integrated using HIV. However, there are other platforms that can be integrated for us to improve the access and improve the testing at the ANC. Other things which can be done is we do have the capacity, and most of the facilities have been testing this using the RTKs. So the capacity is there, and then it is good for us to capitalize on that capacity. I would like to thank the people who did this with us, Micah, Damaris, and Evans, for their support, and also the facilities and institutions that were involved in this, and also the people who did it, the AMREF, the KEMRI, NASCOP, and other stakeholders for this. More importantly, I would also like to thank the Abbott research team for what they did to us and how they improved the tests that we did. On that, I would like to say thank you very much. Asante sana, Masi. Any question, I'll be able to answer. Thank you very much.
Thank you very much. Excellent presentation. Again, we already are getting some questions in the chat, which we will seek to raise during our discussion to follow. So thank you again, Ms. Iani, for your presentation. And now let's move on to Dr. Babak Shanmugam, who's with the Chennai Liver Foundation in India. Babak. Take yourself off mute, please.
Yeah, can you hear me?
Yes, loud and clear. Thank you.
Good evening, good morning, everyone, and thanks, John and Lindsay, for inviting us for this lovely webinar. Today, I'll be speaking about the role of point-of-care testing and how we can scale it across health systems, particularly by integrating screening into community-based settings. My focus today will be on practical, scalable models derived from our own experience. Okay. Right. I think we're going to see this slide over and over again. But Hep B continues to be a silent epidemic. Globally, a lot of people are living with chronic Hep B, and every year we see over 1.2 million people with new infections. But what's more concerning is that only 10% with Hep B know their status and only less than 2 are on treatment. This massive diagnostic gap is what fuels liver cirrhosis and liver cancer and is the reason why community-based screening becomes an absolute essential. The cascade of hepatitis has got multiple steps like testing, linkage to care, treatment, and monitoring. And what it requires is multiple levels of blood testing too. And if each time a patient has to come to the hospital for a blood test, it becomes cumbersome for the patient, cost becomes high, and many a times that's why they're lost in follow-up. So the key is taking the care to the patient. HBV is largely asymptomatic until very late in the disease. So waiting for people to come to the hospital clearly doesn't work, at least in India. Community screening allows us to reach vulnerable groups, people in remote areas and individuals who rarely visit health facilities. It brings prevention, testing, and awareness directly to the population that need it most. Despite the availability of effective tests, screening is still fragmented and opportunistic. It ideally should be more systematic. More testing happens among blood donors, pregnant women, and people who go into the hospitals. But adult men, adolescent, migrant workers, rural populations who are healthy are hardly reached. Stigma, lack of awareness, and poor integration across health programs further reduce the impact. These gaps directly translate to misdiagnosis and ongoing transmission. The core objective is simple. We want Hep B testing to be universal, accessible, and stigma-free. Integration allows early diagnosis, timely linkage to care, vaccination of contacts, and overall reduction in transmission. When hepatitis service becomes part of a routine community health delivery, the entire systems become stronger and more equitable. So this is our own published paper where we did a Markov modeling to understand the economics, the health economics of hepatitis B testing. We clearly demonstrated that decentralizing a linkage to care and vaccination has been significantly better than the conventional approach of screening patients who come into a hospital. So this was, we published this quite some time ago, but unfortunately still, it's not been adopted in our country. So there are multiple existing platforms like my previous speaker alluded in his lovely talk, where they combined the antenatal screening with hepatitis B. Of course, you can screen in primary health centers, health and wellness care centers, and of course, NGOs like us do a lot of outreach programs where we go out in the community and screen these peoples in various health camps and mobile units. And of course, the huge chunk in India, which we feel is a private practitioner. The health system is skewed where a lot of people go into the private sector rather than the public sector. So I think the private sector should also be tapped into and encourage them to screen these patients, and if found negative, then they have to be vaccinated. Each of these settings provide a unique opportunity to expand screening without needing any major infrastructure. Now, this is our own foundation, Chennai Liver Foundation. Of course, you can see my father on the far right. We've got a mobile van which runs around on a day-to-day basis in various towns and villages. And a lot of CSR partners help us overcome barriers faced by the government facilities. We reach the undeserved areas, urban slums, schools, workplaces, and migrant populations. Their program often includes education, testing, which is critical for reducing stigma and increasing health literacy. Flexibility is a major advantage. We can operate outside rigid government rules. Of course, health camps, typically we always liaise with the local governmental organization or another local NGO or another CSR partner or another social organizations like Lions or Rotary, and the people are informed well ahead that such a camp is happening. And it's highly visible. We generate a lot of awareness. A lot of pamphlets is being distributed. And of course, we always have counselors in such gatherings where they can educate them straight away. what is important in our camps is that once found positive, blood is drawn for higher testing, and of course, for those who are negative, we always vaccinate all these people straight away. Of course, this is our, again, published paper we did about 7-8 years ago, where over 75 camps across, I think 14-15 districts of Tamil Nadu. We had a HBV prevalence of 1.63 and a HCV of 0.3, which probably is slightly different now. But what we realized is community health camps remain one of the most effective ways to reach large populations in a short time. Camps can be standalone hepatitis events or integrated with what we do now is a non-communicable disease screening, which is diabetes and hypertension. People receive rapid testing, counseling, and vaccination. And those who test positive are linked to government or private specialists for confirmatory tests and treatment. Thereby, linkage to care is never, ever, ever missed in any of our camps. Of course, this is, I couldn't pull out the data in the last year or so, but this is the last 4 months alone, we've screened close to 2,500 people. And as I said earlier, we started screening for diabetes and hypertension. In fact, we picked up a lot of diabetics and hypertensives because India is got a lot of metabolic diseases. And of course, at the same time, we screen for B and C as always. So we compare our screening models, integrating screening into clinical services. And we understand that when clinical services do screening, it's least costly because infrastructure is always there. But what happens is we screen less number of people because people walking into any hospital is very less. But then when you go out into the community, the screening becomes more, but the cost marginally increases. Expanding community-based screening to include multiple groups further increases the cost per screening because of additional management costs. But I personally feel it is worth it screening for other diseases at the same time because that attracts more people into the community. So two things which I have noticed over the last few years is that when people go out for screening, they draw blood, come back to the institution where they come from, and do a testing in the lab. But I feel the point of care testing is the best. Point of care testing is central to scaling hepatitis screening. They're fast, accurate, require no lab infrastructure, and can be done by frontline workers. POC testing allows diagnosis, counseling, and vaccination to happen all in one encounter within a matter of 15 to 30 minutes. It reduces loss of follow-up and improving linkage to care. This creates a powerful public health advantage. So we almost always do in the community point of care testing with recognized test kits. Of course, we all know the WHO criteria, the assured criteria, where the point of care testing should be affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and of course, easily delivered to the end user. There are various studies around the world which show that point of care testing is extremely cheap. This one from Belgium, where the migrants in Belgium were screened, and it's clearly demonstrated that POC testing at a lower cost when compared to venipuncture sampling. This again, yet another paper from Guatemala, another LMIC introducing point of care testing and antenatal screening showed that they increased the antenatal coverage by 32.5% as shown by our previous speaker, and the hepatitis B screening from 0 to 42.2%. That is quite an increase. So there is no doubt that point of care testing is very, very beneficial. So for successful integration, we need consistent supplies of a rapid diagnostic test, well-trained frontline workers, simple referral pathways, and data integration and digital platforms. Community engagement and political commitment are also critical enablers. Stigma remains the biggest barrier. People fear testing due to misconceptions. Supply chain brings, weak referral systems, and limited follow-up are other challenges. Strengthening and coordination between the PHCs, district hospitals, NGOs, and private providers is quite essential, else the whole system becomes a failure. A robust monitoring and evaluation framework is required. We need to have all the indicators as the number screened, how many are reactive, how many confirmed, and how many have been linked to care. And extremely important that we offer vaccination services in the community to people who've been detected as negative. And of course, we always integrate all the data with the National Viral Hepatitis Control Program. These metrics allow programs to track and impact and refine the strategy. And summary, if we integrate point-of-care testing, hepatitis B testing across platforms, we can drastically reduce the burden of hepatitis B and move every country to closer to elimination. Of course, there are still many unanswered questions regarding funding mechanisms, program sustainability, best way to ensuring linkage to care, especially in a country as big as India, and how to develop, select, and implement the most cost-effective strategies of screening, disease surveillance, and community engagement. But still, I think if all of us join together, I'm sure this is going to be a reality. And by 2030, we will eliminate viral hepatitis. Thank you very much.
Thank you very much, Vivek. Excellent presentation of the published data and your own experience locally. And you bring up the role of multiplex testing in community-based screening programs, and that's something we really want to focus on in our panel discussion. There's also several questions in the chat from my colleague Vivian Wang regarding the known sensitivity and specificity of the multiplex test and which manufacturer is producing the tests that are being used in India and Kenya. So if you have answers to those questions, please send those on at this time. And if not, we'll raise those during the panel discussion. Thank you. Let's go now to our next presentation. Please, this is my colleague, Dr. Jibril Nadal, who's our Director of Research for the Center for Operational Research on Hepatitis B, Core Hep B, which is a component of the Coalition for Global Hepatitis Elimination. Jibril?
Thank you very much, John. Can you see my screen?
Yes.
Yes. It's good to follow up on the earlier two presentations. I will talk you through the current models of care for hepatitis B testing and service delivery. And to get us started, I would start with this systematic review and meta-analysis published earlier this year, which looked at the hepatitis B service delivery over a 10-11-year period from 2013 all the way to 2024, which was done as part of the WHO guidelines update last year. And the thing to point out here is the main thing is that most of our studies looking at hepatitis B testing, care and treatment are happening not in low and income countries where the burden is highest, but in other settings. Only about 40% of these studies happen in LMICs. But the other thing to point out is the types of studies that are being conducted. You would see that most of the hepatitis B care is still happening at hospital levels or within specialist care settings, and that is this color. And very little integration is happening either at antenatal clinics or in HIV or NCD clinics. We're doing very little integration. And third is we're doing very little care that is decentralized at the community level. So community test and treatment programs are very few and almost never happen in our LMIC setting. So most of hepatitis B care is still being done at specialist levels, even when testing happens elsewhere. Looking closer at this in terms of the cascade of care for hepatitis B, again, we see that primary care for this is happening very few, but the thing I want to point out here especially is the rate of attrition, that is the rate at which individuals drop off through the cascade of care. You'll see that in almost all of the 106 studies from 110 cohorts that were analyzed in this meta-analysis, the earlier parts of the cascade of care, which is the testing on this side, seems to be fairly well conducted. But as you move further into the number of patients who have been assessed for treatment eligibility, initiated on treatment, retained in care, and who are virally suppressed, we see less and less of those reports. And this is a reflection of the proportion of patients who are lost during this cascade of care. And all of these just go to strengthen the case that we need to simplify and decentralize hepatitis B care if we want better coverage for individuals. Currently, the traditional models of hepatitis B care in low and middle income countries are one of these two options. It's either hepatitis B testing is happening for suspected cases, individuals presenting with suspected liver disease at a hospital or specialist center who would get tested for hepatitis B, either lab-based surface antigen testing or point of care. And then in a subsequent visit, they will see, for those who are hepatitis B surface antigen positive, would have additional investigations to determine their treatment eligibility, staging of liver disease, and other investigations that are required for them. And then a third visit is then scheduled where a treatment initiation decision is being made. And each of these steps represents opportunities for patients to be lost to follow-up and to drop out of care. Another model that we see more often in LMIC settings are decentralized testing, either in the community or in other settings, followed by referral of hepatitis B surface antigen positive individuals to a specialist setting where they have their investigations done to determine disease stage and treatment eligibility. And all of these would usually require at least 3 separate visits before a treatment decision is being made, with a time lag from diagnosis to treatment decision of usually 2 months, could easily be more than that. To address some of these gaps, we've established the Center for Operational Research on Hepatitis B, or CORE-HepB, where the mandate is really to launch operational research projects that can simplify and decentralize hepatitis B care in low and middle income countries, bring together collaborators and stakeholders who can make this possible, and connect research initiatives to share best practices, see what is happening very well in other settings that can easily be adapted to another part of the world. And to gather all of these findings and use them for policy change for better service care delivery. And if we're able to do all of this, increased testing, increased linkage to care, increased treatment initiation for the 254 million individuals with hepatitis B, eventually we'll start to see a decline in mortality from hepatitis B and the morbidity in terms of end-stage liver disease from hepatitis B infection. The center has 4 main priorities, one of which squarely is aiming to simplify the delivery models of hepatitis B, making sure that these are in a decentralized, equitable access for testing, linkage to care, treatment, and retention in care. And this sits very well in line with the recent recommendations by the WHO in terms of hepatitis B treatment, which now recommends antiviral therapy for all adults and adolescents with chronic hepatitis B infection in the presence of significant fibrosis defined by APRI score more than 0.5 or presence of clinical cirrhosis, or elevated hepatitis B DNA of 2000 with an elevated ALT level, or presence of other risk factors, which include co-infection, family history of liver cancer or cirrhosis, comorbidities, immunosuppression, or extrahepatic manifestations of hepatitis disease. And if you're in a setting that doesn't have access to hepatitis B DNA, treatment can be initiated for individuals with a persistently abnormal ALT above the upper limit of normal. I like to flip this on its head and just present it in another format, which is that most individuals are eligible for antiviral therapy by the new WHO guidelines, unless those who have a persistently abnormal ALT and hepatitis B DNA less than 2000 and do not have any risk factors, such as co-infection, family history, and others. And this helps us simplify our care and how we approach delivery of hepatitis B care. And with these guidelines, we estimate that at least half of all patients who are hepatitis B infected will be eligible for antiviral therapy. And this represents an urgent need for us to decentralize hepatitis B care out of the specialist centers and hospitals down to the primary care level where most of these individuals live. That is the only way we'll be able to do this. And in light of that, we need to develop new models of care. And here we present options 3 and 4, where it can be either in option 3, hepatitis B screening still happens somewhere else, either at a primary care center or at the community level, and then linkage to care at a primary care center where all of the investigations are done and a treatment decision taken on the same day. And this reduces the time between diagnosis and treatment initiation, and hopefully would reduce the different steps which can lead to attrition and loss to follow-up. Or the ideal model would be a same-day test and treat. This is option 4, where hepatitis B surface antigen screening is done at a primary care facility, or this can be at an antenatal clinic or an integrated clinic somewhere in a decentralized manner. And then on the same day that an individual tests positive for hepatitis B surface antigen, additional follow-up diagnostic tests can be done to determine their treatment eligibility and their risk factors, and then a treatment decision is made in the same day. These same day treatment initiations would not require any follow-up appointments, which could present a risk of loss to follow-up, and it could make hepatitis B care more equitable and more accessible, especially in rural settings where most of the individuals live. So a toolbox for hepatitis B same-day test and treatment would normally require a surface antigen point of care testing, which is widely available currently in most of our settings. It would require an ability to be able to do hepatitis B DNA viral load, or an alternative to this that can identify individuals with a high viral load, and some degree of identifying the ALT level in the individuals, and ideally fibrosis assessment as well. So what we currently have is we have the surface antigen test kit as a point of care format. Hepatitis B DNA viral load is available in a near patient setting in some sites which have access to GeneXpert, but in settings where we don't have these, there are new point of care markers, diagnostic markers, particularly hepatitis B correlated antigen, which now comes in a point of care format that have fairly good performance in identifying individuals with hepatitis B DNA above certain thresholds. And we are now having ALT point of care tests that do not require sophisticated laboratory platforms that can be implemented in this decentralized same-day test and treatment. The weak point of this model would be the fibrosis assessment, because currently the simpler non-invasive point of care test for fibrosis assessment is the APRI score, which requires platelets and AST, which are not available outside of conventional labs. There are new markers for fibrosis that have been developed in China that could be leveraged, but at least at the very minimum, we can have surface antigen diagnosed, some form of viral load indication, and an ALT, all decentralized at the primary care level, even in centers where we don't have laboratory support. Just a little bit about the ALT point of care. It works like the lateral flow test that we are all commonly familiar with a finger prick blood. On the test prototype, it can detect levels of ALT and give semi-quantitative indication of the level of ALT above or below a certain threshold. This is currently being developed by Burnett Institute. The current format could come with a reader that would actually tell you an exact quantitative value of the ALT. The test requires very minimal blood volume, and results are usually available within 20 minutes. Core Hep B is working with Burnett to see how we can further simplify this, both in terms of how it can make the testing easier, but also how it can go without a reader version, which will make it more cost effective and affordable for low income settings. And the correlated antigen test operates in a similar manner, where you have either whole blood, plasma, or serum sample on the test, and then with a runtime of 30 minutes, you get your results for the existing version of this. And in this study, which was led by Yusuke Shimakawa, which involves patients from several African countries, we looked at the performance of the correlated antigen test in identifying individuals with high viral load. And we especially included hepatitis B genotypes that are commonly prevalent in Africa. That's genotypes A and E. And you would see here that the higher the hepatitis B viral load, the more sensitive the test is. And currently this test is being approved as a highly sensitive e-antigen point of care test, which can be deployed in antenatal settings for identifying pregnant women with high levels of viral load who are eligible for antiviral prophylaxis. And we are working with the manufacturers to further improve the sensitivity and specificity of this test at lower levels of viral load threshold above 2,000, so that this can also be deployed for non-pregnant adults with hepatitis B who are being assessed for treatment eligibility at a threshold of 2,000 level of viral load. And this is the study that we are proposing to test these new point of care markers for coronary antigen and ALT in the field. We are doing this study in Ethiopia, Gambia, and Malawi. The study would be done completely in primary care settings. It will be led by non-specialist physicians, either by nurses or the community healthcare workers, where individuals would be tested for hepatitis B surface antigen using the point of care test, and those who test positive will then have a brief history taken and a physical examination to look for signs of cirrhosis, family history of liver cirrhosis or liver cancer, then followed by, on the same day at the same spot, 2 point of care tests, one for the ALT point of care to determine if they have an ALT above or below the upper limit of normal, and the second coronary antigen point of care test to determine if they have a viral load level above or below 2,000. And with this, we can reach a treatment decision based on the 2024 WHO guidelines. All individuals will be started on either monotherapy using TDF or dual therapy, which is the combination, and will be followed up every 6 months if they are not on treatment, or every 3 months if they are on treatment. And we'll be looking at outcomes, both at the individual patient clinical outcomes, viral load suppression, ALT normalization, and at the programmatic level in terms of how has this expanded care in these settings. And I would just wrap up here by showing you 2 examples of simplified models of care that we have tried in various settings that have shown really promising results. The first one is a simplified model of care for hepatitis B and C alongside other STI testing that we have done in a rural part of the Gambia in the Basse region as part of a phase survey, which was looking at HPV serotypes in preparation for an HPV vaccination program. But what we've done here is that in a rural population, women of childbearing age were invited for testing for a series of infections, hepatitis B, hepatitis C, HIV, syphilis, and then samples collected for HPV testing in the lab. And the most important things I want to point out here is the level of acceptance of this decentralized multiplex testing for various diseases. Almost all the women agreed to be tested. Amongst those who were tested in the community, when we set up a primary care facility near their villages, we had an 86% linkage to care, which significantly surpasses other linkage to care that we've seen when patients are asked to go to a centralized reference center. Only about 41 or so individuals declined the linkage to care, and amongst them, most of them actually agreed to come, but the date that the clinic was set up was not favorable for them. So this represents a simplified version where testing is decentralized and then linkage to care brought nearer to the patient, which represents significant linkage to care proportion. And the second is an integrated model where we integrate hepatitis B testing and management within an ANC clinic. This study was done in the Gambia and Burkina Faso, where we both tried new point of care diagnostics and then integrating hepatitis B prophylaxis and long-term care after delivery within the antenatal site settings. Prior to the study, we did an assessment to understand, like what is the actual coverage of hepatitis B testing and how is hepatitis B care provided during and after pregnancy. We conducted the study where all individuals, all pregnant women were tested for hepatitis B surface antigen at their first antenatal visit. And then we followed this up immediately by assessing those who were eligible for prophylaxis. Pregnant women were followed up all through delivery. And then after delivery, we then linked them back to care, mostly at the same facility where they came for antenatal services for their own long-term follow-up assessment. And the key message is here, and I think this is my last slide, is that generally we found that healthcare worker knowledge about hepatitis B was much lower when compared to hepatitis C, and this also translated in the care that was provided. Most of the women were getting testing for HIV and for syphilis, but hepatitis B testing was much lower in both countries. And then for cascade of care, when we offered the testing, almost all the women accepted to test for hepatitis B. We were able to do an assessment for prophylaxis eligibility on the same day for 86% of the hepatitis B surface antigen positive women, and more than 2/3 of them were retained in care throughout pregnancy. And this was especially high for those who were on prophylaxis. During this study, we found a very high coverage of timely birth dose vaccination, 92%, which translated in a much reduced risk of mother-child transmission. We had one case of infection in the Gambia, and this was a unique case where the mother had exceptionally high viral loads and refused to take prophylaxis. That's for another discussion. The most important thing I wanted to highlight here is that when we offered linkage to care services for pregnant women, that was brought again nearer to them, to the same antenatal clinic site where they came for care during pregnancy. We found very good in our preliminary results, 73% linkage to care. And this was, most of the women whom we could not successfully link to care were those who had adverse pregnancy outcomes. And this is, I think, quite understandable. Thank you very much. I'll stop here now.
Thank you, Jabril. We have a very active Q&A discussion going in the Q&A section. So please join that with your questions as well as your comments in the chat. Some of those questions are being answered along the way, and we'll be seeking to raise those in our panel. But let's go to our last speaker for today. It's Dr. Sylvia Stratilat, who's the head of HIV and viral hepatitis Surveillance Department in the National Public Health Agency of Moldova. Sylvia is a longtime colleague, and we greatly welcome her to this webinar. Sylvia.
Hi, afternoon. Good afternoon to all. First of all, I would like to thank to the Coalition for Global Hepatitis Elimination for invitation, the opportunity to learn how to apply practical strategies and expand hepatitis B screening, but also to share our experience of Republic of Moldova in this return. Next, please. Slide. Viral hepatitis presents one of the challenges in the Republic of Moldova due to its increased morbidity and mortality. Of course, according with our statistical data, of total cases of chronic hepatitis, about 66.7% are of viral etiology. There are officially registered about 31,000 cases of chronic hepatitis B and around 17,000 cases chronic hepatitis C. At the same time, I would like to say that there are estimated with hepatitis B about 43,000 persons, and with hepatitis C about 55,000 patients. Of course, respectively, only 70.2% of patients know their status with hepatitis B, and respectively, only 30.2% of patients with hepatitis C know their status. Please, next, please. Next. Dynamics of viral hepatitis B and C morbidity in Moldova indicates a decrease of acute hepatitis incidence and increase of chronic forms. This is due to the prevention measures implemented, including vaccination against hepatitis B, which was been included in the National Immunization Program since 1995, and implementation of infection control measures, but also increasing access to testing for detecting case of chronic hepatitis. Screening with rapid test in the last 5 years has contributed to the detection of chronic forms. Thus, the incidence per 100,000 population in 2024 for acute hepatitis in Moldova is 0.4, and for acute hepatitis C is 0.9. Comparability with chronic hepatitis B, that is 23.3, and chronic hepatitis C, that is 45. Next, please. I want to mention that hepatitis has a high seroprevalence in populations at high risk. Seroprevalence studies conducted in the country among people in increase of risk have indicated a high seroprevalence for both hepatitis B and hepatitis C. Viral hepatitis B among injection drug users, sex workers, and MSM has a seroprevalence of about 3%, while hepatitis C seroprevalence among injection drug users is very high, 49.3%. Among sex workers is 8.6%, and among MSM is 4.7%. Next, please. Moldova has been implemented a lot of efforts to increase the detection of people with hepatitis and in aim to detect chronic hepatitis. So, starting with 2020, universal access to screening with rapid tests is ensured for all people with a complete geographical coverage that is available in primary healthcare points. In harm reduction settings for key populations is provided screening tests for hepatitis B and C with rapid tests that are provided by NGOs. Also, screening testing for hepatitis with rapid tests is accessible in penitentiary system that are approached from state budget resources. And GenExpert methods are applied to confirm diagnostic and, of course, monitor DA treatment. Next, please. Special attention is paid for people with the increased risk of infection, especially for injection drug users, for MSM, for sex workers within the risk reduction programs. For these populations is implemented an integrated approach in our country of prevention service for HIV, STI, and hepatitis. Services are provided according to the standard of organization or operation of HIV prevention service in the environment of key population, including for young people from these groups. This standard is approved by Ministry of Health, and the prevention service package for this population includes prophylaxis, testing, and treatment for viral hepatitis B and C. Next, please. So, hepatitis testing being a component of prevention service package is financed from state budget, and it is reported and monitored like other components of the prevention service package, like condoms distribution, syringes, HIV counseling, referrals, and tuberculosis screening. Please, next. Hepatitis testing for people at increase of risk is provided through several methods, including in points of syringe and condom distribution. Testing is also provided with the field trips to place frequented by people at high risk to infection, and in mobile units at a distant place, but testing is also promoted by online networks. Thanks. Next. Several non-governmental organizations are involved in providing testing for hepatitis. Also, a rapid test is provided for drug injection users by 10 NGOs in about 40 localities in civil sectors, but is also accessible in penitentiary institution in 18 institutions. For sex workers, also 10 organizations, non-governmental organizations provide testing for hepatitis with coverage about 30 localities, and for men, sex with men, the hepatitis testing is covering in 17 localities by 6 NGOs. Next, please. Thus, in NGOs in 2024, with rapid diagnostic test, were tested around 14,000 people for HBs antigen, of which about 2.7 were with positive result, and around 17,000 for anti-hepatitis C, of which around 7.8% were with positive result. Next, please. As I mentioned previously, testing for hepatitis is accessible as well in healthcare settings. And in 2024, around 103,000 people were tested for HBs antigen, with that, around 3,500 were with positive result, and around 94,000 were tested as anti-HCV test. Next, please. For the purpose of testing, of course, is to identify positive individuals and confirm the diagnosis, and of course includes them in DA treatment. Respectively, an important aspect in providing hepatitis tests is given for referrals and accompaniment to organization or institution that provide service for populations with increased risk. Thus, persons with positive result are referred to healthcare settings for confirmation of diagnosis and inclusion in the DA treatment. Those with the negative results are referred to vaccination and vaccination offices or other services need, including STI diagnosis, opioid treatment, pharmacological treatment of opioid addiction, etc. Next, please. Referring hepatitis testing, we could note some achievements in Republic of Moldova, one of which is the regulatory framework regarding the provision of testing for HIV, hepatitis, and STI. That is approved by Ministry of Health, and this standard is applied in practice. The other one I can mention an integrated approach to HIV, STI, hepatitis testing that ensure testing for all three infections, and providing testing in the field of affected communities by NGOs that ensuring targeted testing for people at high risk of infection. I also would like to mention that the funding for testing is provided from state budget. The country assumes this cost, and of course, assuring all basic intervention testing, antiviral treatment, and vaccination against viral hepatitis. It is very important to point that testing is accessed in penitentiary system and with coverage and access national worldwide. Next, please. At the same time, I would like to mention some barriers and challenges in our country. One of them is lack of intervention carried out at national level to increase awarenesses and inform the population and group at risk regarding the benefits of testing and treatment for hepatitis. This is determined by insufficient funding of interventions to raise awarenesses of the populations, including intervention for group at increased risk and the general population. And respectively, in the country, there are no massive screening testing campaigns that at the national levels, including in the rural areas, to and remove locators. Next, please. I would like to say thank you for attention, but I think with the joint and persistent efforts in in our countries. By ensuring testing and DA treatment, we will achieve elimination of virus in our countries. Thank you, and good luck for you. Thank you.
Thank you so much for that in-depth description of the program, as well as the achievements and challenges along the way there, Sylvia. Really greatly appreciate it. To kick off our panel discussion in QA, I'm going to turn it over to Dr. Cuckoo Appiah, who's the Global Medical Director of Abbott Rapid Diagnostics, for some remarks and comments on the presentations and on the test availability from Abbott. Cuckoo?
Thanks so much, John. And welcome everybody to this very excellent webinar. It's been very interesting to listen to how different settings and different countries are looking at integrating and expanding hepatitis B testing in the context of antenatal care and other models. So Abbott has a proud legacy of providing innovation in the area of point-of-care testing, diagnostics for important infectious diseases. Sorry, can you not hear me?
No, please go ahead, Dr. Cuckoo.
Oh, sorry. So I'm saying that Abbott has a proud legacy of providing innovation in the area of point-of-care diagnostic innovation for important infectious diseases such as viral hepatitis B and C, HIV, and syphilis. Despite strong national commitments towards triple elimination of hepatitis B, syphilis, and HIV, these diseases still continue to affect thousands of mothers and babies across Africa. This is threatening the health of future generations. Many countries have achieved or are close to achieving their targets for screening and management of HIV within the mother-to-child transmission setting, but there still remain significant gaps in the screening of pregnant women in resource-limited settings for syphilis and particularly for hepatitis B. Abbott is honored to be part of the shared vision of triple elimination and also remains committed to deepening collaborations to protect mothers and safeguard future generations through prevention of mother-to-child transmission. We are proud to, as Abbott, to have received the recent WHO pre-qualification. We have placed the announcement in the resources setting. So we recently received the WHO pre-qualification for the first global triple elimination multiplex panel. It's called the Determine Antenatal Care Panel. This is a breakthrough in rapid diagnostics, and it delivers lab-accurate detection of 3 life-threatening infections, as I said, HIV, syphilis, and hepatitis B, through a single finger stick sample at one visit, and it also enables then a test and treat to trigger test and treat for these different diseases. So this is designed specifically for antenatal settings, and it's optimized for use in resource-limited settings. An adoption of this Abbott multiplex test supports key global imperatives, such as the integration of care, the optimization of workflow within the healthcare setting, and looking for improved outcomes that will lead to gains in maternal and neonatal morbidity and mortality. And this, the adoption of the ANC panel, the Abbott multiplex test, ultimately supports WHO's goals for safer pregnancies and for healthier babies. Thank you very much.
Thank you very much, Cuckoo. For those that have questions, specific about the Abbott assay, please put those in the Q&A for Cuckoo's response. If we're not able to get them on the screen verbally. So thank you again for that. It's a great round of presentations, and in looking those over, there was a focus on the role of integrated multiplex testing for screening pregnant women for hepatitis B as well as HIV and syphilis to eliminate risk for perinatal transmission. Vivek focused on community-based approaches and how multiplex testing can benefit that. Jabril focused on the importance of integrating a point-of-care testing within simplified models of care so that we can expand access to care and treatment. And then Sylvia focused on the role of testing for key populations such as MSM and people who inject drugs. And we had a variety of questions regarding those different uses. But just to focus on the role of multiplex testing of screening of pregnant women, Masiani from Kenya, is the multiplex testing now getting scaled up in Kenya, or is it still only in pilot programs? What's the prospects of that becoming the routine way of screening pregnant women with the use of integrated multiplex testing, please?
Thank you very much for the question. For now, we are thinking on how to roll it out. When we did this, it was a pilot. And in that pilot, what we did was to showcase how good the multiplex is. And the test by then was not approved by WHO. We are now happy that this test has been approved by WHO, and now it is in use. So we are in discussion with the government, and the government is so much willing on how to implement the result that we had. And it is in process and it is in progress. Recently, we started testing of hepatitis, and I'm sure now the multiplex will be very useful in Kenya.
Mm-hmm. Thank you. You pointed out, you gave some data to show that it was more cost effective to have an integrated multiplex approach rather than single testing. Was that type of information very helpful in convincing the national government to move in this direction?
Yes, for sure it is. Because in such a time where the testing and all that and the funding toward the test is really limited, having something that is affordable is a way to go. And therefore, the results which we had, specifically how it can reduce in terms of the ANC at the ANC level, and also at the mother who was coming, and specifically in remote areas, it was a good way. And we are in discussion with the government, and it is so much willing to look at our results and see what we can do. And something else which I can say at this particular moment, especially when it comes to the testing, is that we do have diverse populations and diverse needs. And therefore, having a test that is able to meet, especially to reduce time and also to increase the sensitivity and the management of the patient, for sure, it is a game changer.
Thank you. Vivek and Sylvia, what's the status of hepatitis B screening of pregnant women, to your knowledge, in India, Vivek, or at least in your state, in Chennai? And then for Sylvia, are women screened for hepatitis B in Moldova? And is there a role for integrated HIV, hepatitis B, syphilis testing in Moldova? Thank you. Let me start with Vivek first and then Sylvia second. Thank you.
Thank you for the questions. In our countries, we test pregnant women with separate, for hepatitis B separate, C and B separate, and for HIV and syphilis is multiplex tests. And of course, this is more costs. And we think in future we will introduce multiplex test for HIV, syphilis, and hepatitis. But at the moment, we don't apply multiplex tests for
Thank you.
HIV, syphilis, and hepatitis. Thank you. But
Thank
of
you.
course, the testing is accessible in the healthcare points, and all pregnant women are tested at the first trimester of birth.
Thank you very much.
Thank you.
Thank you. Babak, please.
So as far as India is concerned, triple elimination has caught on only in a very few states. There are close to about 30 states. But hepatitis B testing is definitely happening. We have, I can't give you a number though, but all institutional deliveries are definitely screened for hepatitis B. But having said that, there is still a sizable portion of deliveries happening outside the institution where testing may or may not happen. But triple elimination is catching up. At least 3 or 4 states have taken it as a policy, India state, because health is a state subject. And though India is a big country and health is individualized to all the small states. So that's catching up. And we in Tamil Nadu are going to do that very quickly as well.
Thank you. Cuckoo, a quick question for you. We put in the chat, that multiplex testing is available from a variety of manufacturers, but Abbott is available here. And there were several questions regarding access. Can my country, such as Ghana, have access to multiplex testing? So as best as you can you give us some idea of the availability of the Abbott multiplex testing in various African countries at the moment, and what are the plans going forward for that? Thank you.
No, the test is it's a WHO pre-qualified, which is a key barrier to achieve in most countries in Africa. And also we are undertaking in-country evaluations in a number of African countries. These tests are, the tests that are contained in the ANC panel are tests that are already registered and in use as individual tests in many African countries. So it's the Determine Early HIV Detect, it's the Determine HBsAg2, and it's the Determine Syphilis. So they are registered and in use already in many countries in Africa. And so what we are focusing now is the usability of the triple panel. So allowing countries to test how this works within their health settings. And we have those studies underway in a number of countries. Ghana, which is where I come from, is also on the horizon for this kind of testing. And definitely we have representatives in all African countries who are engaging with the Ministry of Health in the first instance to be able to bring the tests like other Abbott diagnostics into countries that need it. Thank you.
Thank you. There are several questions regarding the availability of this test from Abbott in the United States.
So that is, yes, it's not really optimized at this stage for the United States. There are a number of other regulatory hurdles that would need to be met in order for it to be in the United States. But what we have now is the World Health Organization pre-qualification. So for countries in which that is significant, then we're good to go.
Thank you so much. The second stage of this was several questions and comments around family-based testing coming from maternal screening. And I was going to turn it over to Jabril to, for you to comment about some of our plans for, looking at the role of multiplex testing in screening pregnant women and then by extension, the family. Would you please comment on that, Jabril?
Yeah, it's very exciting to see that in other places, the multiplex testing has been used in antenatal settings, and the general kind of like feedback is that it works very well from a provider point of view, and it's also preferred by the pregnant women. So we're looking to to use this multiplex testing in pregnant women cohorts in parts of Africa, in Uganda initially, in antenatal clinics where we would be doing this targeted multiplex testing under the banner of the triple elimination agenda. And then hepatitis B surface antigen positive pregnant women would then be indexed for decentralized risk-based testing for their household contacts, their children, their partners, and other close relatives. And hopefully this can provide targeted care and intervention for them, but it also can feeds into the integration and doing things in a coordinated manner rather than in silos. So multiplex testing at antenatal services where the pregnant woman will get all the care they need, but then using that as a stepping stone into the community to then provide testing for their household contacts and other close relatives.
Thank you. Ms. Siani, since you're a little bit further along in looking at integrated testing, have you thought about, and I know in many countries, I'm not sure about Kenya, there is outreach to family members when a mother is found to be HIV positive. Have you thought about the role of this integrated multiplex testing in screening family members for hepatitis B, given their high risk of household transmission of hepatitis B virus, please?
Yeah, thank you very much for that question, because I have used these tests at a community level. Let me start with this, that during this testing, especially when doing this test, one of the main challenge was on how to link them to care. And when you tell somebody that he has hepatitis, then it's like, where did I get it from? What about my family members and all that? So we started it specifically when we were doing this pilot. We visited the families that were affected. We also linked them to care. And the definition of linking to care is we were able to take them through all the other tests, that is the LFTs, the viral loads, and link them to care. Not only that, we also vaccinated the children that we got from testing all this. So that led us to the second study, which I didn't present here. We did a community-based, and the result from community-based and what Gabriel has shown were actually so similar, that people were willing to take it up at the community level, and they were willing to be screened, to be tested for hepatitis, and also the other two tests. So this kit especially, which is the multiplex, is very useful, especially in following up. So if you have somebody who is positive, you can use it to go to the family members, especially the spouse and the other close relatives. I have used it and the results are amazing.
Thank you. Vivek, regarding community-based approaches, do you agree that it really has a lot of advantages for simplicity and linking the care of these multiple diseases in Chennai?
Clearly so. I don't have any doubts about that. Especially because, as I said, we don't have multiplex testing yet in India, though. So diabetes and hypertension, which is the NCDs, because MASH or metabolic associated steatohepatitis is a huge problem. Fatty liver disease is a huge problem. So we have now started screening for those things in the community. People always have this stigma of coming into a hospital. They feel the cost is high, and they feel that the hospitals are going to charge them more for various other things and tablets and medications and so on and so forth. So I think in the community they're a bit more relaxed. When we take the care to them, they trust us with their family, and it's easier for us to get them treated. And we always accompany with a qualified doctor. So in case of any doubts, it's clear then and there, number one. Number two is a linkage to care is for sure. So I think community testing is the best. Point of care testing is amazing.
Thank you. Ms. Siani, do you have another comment?
Yes, my comment on the community and also integrating it in HIV is about stigma. If we do have a very nice way to counter stigma, especially by including the counselors and taking through the person who we are doing the testing, the stages of counseling, it will really, really help. Initially, we had not foreseen that, but later, after realizing it and we integrated it into the process, it really saved a lot, and it gave us a very nice way of reaching out to many people. So countering the stigma will really, really help in terms of integrating this and having high success rate.
I think, Vivek, you touched on this. When you speak about community-based testing, is it more just outreach, like health fairs and sort of, right in the shopping centers, et cetera? Or does that also include primary care where people are coming in for general care? And then I could see how this would also be very helpful as a preventive service by primary care providers. So what's your concept when you speak of community-based testing?
Of course, earlier days we were doing, as I said, we used to normally would tie up with another social organization like a Lions Club or Rotary Club, announce a week ago as to such a camp is going to happen, and then we go in and in a common place, get all these people in and test them. But recently, what we've also done is tied up with the government of Tamil Nadu. And because they have primary care centers all in the peripheries. So they've given us access for the first time to go into their place and screen patients who are coming into the hospital setting also inside the government primary healthcare centers. Of course, we have a combination of both. I think community is good because even we do random testing, we still pick up patients. Because, as I said, a community in a hospital only a certain group of patients will enter. So I think it has to be a combination of both. I think, of course, a mall. I've never done a mall because I think people come for shopping. They never would like to have their hand pricked, right? But small villages, schools, colleges, corporates, especially youngsters with various kinds of activities. So I think. I think multiple models are required to cover the entire population.
Yeah, thank you. Thank you all. We have just about 90 seconds left. So any last comments from our presenters before we wrap up?
There's a lot of interest in the Q&A and the chat about kind of like these novel diagnostic tools that can support decentralized hepatitis B service delivery in the primary care setting and the integrated. So I would just urge everyone to register to the coalition's newsletter and to keep track of the core Hep B studies. As we launch this, we'll be providing periodic updates. And yeah,
thank you. Well, and thank you all for a fantastic set of presentations, really tremendously informative and tremendously thought-provoking. So I really congratulate you on your work, and please keep it up. And thank you again for your sharing your valuable lessons learned. I think we have an evaluation that we usually put up. And then again, just please sign up to be informed of future webinars in our webinar series. And again, please sign up for our newsletter. If you have any other follow-up questions, please pass them along to me at jward@taskforce.org. And look forward to hearing from you and working together to advance progress toward the elimination of hepatitis B and hepatitis C in your country and globally. Thank you again for participating. And thank you all, Sylvia, Massiana, Vivek, and Jabril. Excellent set of presentations. Great job.